Hello and welcome to my channel. I'll be your preceptor today on this episode of Cath Lab Did What? Today we're going to talk about the three most common diagnostic procedures you will see in the cath lab. As always, for hospital specific policy and procedures, please touch base with your on-the-ground preceptor, check your hospital's policy and procedures. So let's get started. Let's say you have an NSTEMI in your hospital and the physician wants to bring in for a left heart cath. How are we going to get access? What all does this test involve? So the left heart cath is actually refers to two separate procedures that you can do at the same time. This is the coronary angiogram and the left heart cath. So let's talk about this first, since that's going to be one of the diagnostic procedures you do the most frequent. So, the coronary angiogram or left heart cath, these are going to be arterial access sites. You will get typically radial access or femoral access right on the right side, right radial, right femoral. You can also go right ulnar if the radial artery is blocked. If for some reason you can't use the right radial, some physicians will opt to do left radial before they go femoral. For patients who have had a CABG, left radial access is preferred to see those graphs, and we can talk about that later. Right radial access is preferred by the physician because of ergonomics. So the right side, right radial, right fem, the physician stands on the right side of the bed, so it's just easier for them to get access. With radial access, you have lower bleeding and vascular complications compared to femoral access. Patients have faster ambulation times because you don't have to worry about that femoral access site opening back up. It's on their arm. However, there are a couple drawbacks. In multiple studies, there's about a 4 to 8% possibility that you'll have to transition from right radial access to femoral access. And this can be for multiple reasons. Sometimes you just can't get radial access, right? There's an occlusion, they have weird anatomy, you can't get access, you go groin. Sometimes you get access, you put your catheter up, and they have like an occlusion right in their elbow area, or they have extreme tortuosity in the brachiocephalic aspect of their artery. And so you just can't get the catheter from the radial artery up to the aortic arch. So you have to go femoral. Patients have a decreased ability to do self care with radial access at times. A lot of people are right handed, they have radial access. They're asked not to use that arm for 24 hours, pretending that it's broken for a while. So it's harder to do self care, their ADLs. Some physicians, if you can't go right radial, will opt to try left radial first before going femoral. And left radial actually has a decreased incidence of having that brachiocephalic tortuosity. So it has a decreased incidence of transitioning from left radial access to femoral access. It's more of an ergonomic issue for physicians on why they don't like going left radial. The left arm is on the opposite side of the bed from where they are working. And so they'll get access on the left side of the bed. And then you'll have to use something to float their arm across the patient's body for the physician to do the procedure. Another way to get access in that left radial is something called the snuff box. This is located in between the thumb and the first finger. It's distal radial access. It just helps the arm across. It's in a more natural position than trying to put the arm across the body and keep the palm up. You don't have to do that kind of motion with their arm. It also has this snuff box access has decreased risk of forearm radial artery occlusion post procedure. Let's say you have a perforation on access, which does happen. Snuff box has a decreased risk of getting compartment syndrome if there's a perforation. However, the vessel is small in that distal artery, and so it's harder to get access. Femoral artery is one of the bigger access sites. This is what you're going to use if you can't use radial. for right or left for whatever reason, you're going to go femoral. Also, in your high risk PCIs and your really sick patients, not diagnostic, but you'll go femoral because you can put in the bigger catheters, you can put in those bigger like Impellas and balloon pumps and whatever you need to do in the moment. For femoral access, you're going to want to use a micropuncture. It's 56% smaller than an 18 gauge access needle. So it's pretty small. You can put it in, see if you can float your wire up and have like true access. You can even do a peripheral angiogram of that femoral artery to make sure everything looks okay before you float it up. And if for whatever reason the access doesn't work very well and you're going to have to restick, it's a really small puncture so you can hold pressure and it'll be fine. The stick placement for these access in the femoral artery is very important. So you'll see them taking definitely ultrasound. You might see them getting a quick fluoro of the hip before they get access. They do this because they want to get access above the femoral head. This helps post-procedure when we pull the sheath. You can hold pressure over the femoral head so you have a hard spot to hold that pressure. If it's not over like the bony prominence, it's just kind of fleshy and it's harder to really get good pressure and stop that bleeding. The puncture should be above the iliac bifurcation and below the inferior epigastric artery. This is just a great spot, and you can use closure devices. This is where they want to stick for these femoral access sites. Keeping in mind, these access sites account for greater than 50% of all bleeding complications that you will see from these left heart cath coronary angiograms. So it's important to get a good stick. It's important to get access. And when we pull access, which will typically be your scrub, not so much you as a circulating nurse, it's important to make sure that bleeding stops. Okay, so we got access. We're going to put our catheter in through the radial artery, the femoral artery, whichever access we have, over a wire. And we're going to snake it up to your aortic arch. The patient's aortic arch. To do the coronary angiogram, we are going to park the catheter above the aortic valve. So, anatomy time. The aortic valve has 3 cusps. So, it has the right cusp, which is where your right coronary artery is going to live. It has a left cusp, which is typically where your left main lives. And then it has a non-coronary cusp, which doesn't have a coronary artery. People who are outliers, people who have weird anatomy. And so this is just, in general, this is where you're going to find these coronary osteums. For the coronary angiogram, they're going to take their catheter, whichever diagnostic catheter they're using for their coronary angiogram today. Engage either the right or the left first. So let's say they have a right diagnostic catheter in. They're going to take their catheter and they're going to engage the right coronary artery. Engage means they're going to take the tip of their catheter and they're going to put it at the opening of the right coronary artery. And then they can shoot contrast down the right coronary artery, the RCA, and see how the flow looks. Is there stenosis? Is there a clot? Is it nice and open? Is it small? Is it large? And we're going to do that evaluation. This is where your eye will move. They don't always do a lot of imaging of the RCA because the RCA looks like a C. It's one vessel. You do have like the PDA and PLA that bifurcate distally. But in general, the RCA is one vessel. It just looks like a C. That's how you'll know you're on the right. And they'll take 2 angles of the RCA to see how it's looking. Put in a left catheter. There is a catheter, and we'll talk about catheters in a different episode that can engage both diagnostically. But they'll put in a different catheter to engage their left main. So same thing, they're going to put the catheter in. The tip of the catheter will engage the left main ostium, and they will shoot dye down that ostium into the left main, which bifurcates into the left anterior descending and the left circumflex. Some people have a trifurcation off of the left main, and that middle vessel will be called the ramus. So same thing with the RCA. We're gonna take more angles of the left side because there's more vessels, and you want to see multiple angles to see if there's stenosis somewhere that you need to fix. Definitely to see different angles because you can see different vessels better with the different imaging angles. And we can also talk about that later. We're just kind of overviewing the diagnostic. Taking pictures, you put a catheter in that RCA, seeing that it's wide open. Let's just say it's wide open today. You took that out, you put another catheter in, you engaged your left main, you saw your left main, you saw your LAD, your left anterior descending, you saw your left circumflex, the circ, everything looks great. So their coronary angiogram is negative, it's beautiful. So now we're going to do our left heart cath. So we are going to take a diagnostic catheter and we are going to advance it through the aortic valve into the left ventricle. This is your left heart cath. So coronary angiogram is the contrast into the coronary arteries. The left heart cath is the pressure that we're going to get from the left ventricle. So when they advance that catheter, usually they'll put the wire into the left ventricle and then they'll advance their catheter through. You're going to see some ectopy. That wire kind of gets tangled up on the papillary muscles, tickles the left ventricle, and you'll see ectopy. Typically, if the physician repositions their wire, their catheter, the ectopy calms down and you can get a very good left ventricular pressure reading. Sometimes the patient still has some ectopy. Just let the physician know, they usually already know that they're having runs of VT, is usually what you're going to see, so that they can kind of get their wire in a different position or out of the body. So what we're going to look for when we get our catheter into the left ventricle is a left ventricular pressure. This is going to have 3 numbers, just like always. You know, your pressures are your systolic, diastolic, and MAP for just typical blood pressures. In your LV, you're really going to pay most attention to your systolic pressure and that third number. So the diastolic, we're going to ignore. And the third number, which would usually be your MAP, is your left ventricular and diastolic pressure. This is an indicator of your preload. So it's really important in these CHF patients. It's going to tell you how fluid overloaded this patient is. A normal left diastolic pressure, or LVEDP, is 4 to 12. Once you start getting up to the 20-25 range, you're really pushing that fluid overload, and you need to get this patient some Lasix to help get some of that fluid off. So now that we have that diagnostic catheter through the aortic arch and we have our left heart cath done, we have our left ventricle pressures, we're going to do something called a pullback. You're going to get your LV pressure, and then the physician is going to pull his catheter back into the aortic arch across the aortic valve. Then you're going to compare the systolic of the LV and the systolic of your AO, so your central aortic pressure right outside the aortic valve. 2 systolic pressures should be similar. This pullback tells us if there is aortic stenosis, there's any kind of aortic insufficiency. If there's a gradient, your LV systolic pressure is 140 and your AO systolic pressure is 130, you have a 10-point gradient. The AO is lower systolically than the LV, and so you have some aortic stenosis. The larger that gradient, the more severe the stenosis. What we do need to keep in mind with this pullback is the patient has to be in sinus rhythm and with a regular rate for this to really be an accurate measurement of your aortic stenosis. Typically, the physician is going to know going in if this patient has had aortic stenosis on like echo, and they're going to know if there's some stenosis depending on how hard it is to get their catheter through that aortic valve. Another way to kind of do this gradient measurement is with a dual lumen pigtail catheter. So you're gonna have to have two transducers. With the first example, with just a pullback, you only need one transducer, which is like your assist, your manifold, whatever your hospital uses. You only need one. You go when you get the LV pressure, you pull into the aortic arch. With the dual lumen pigtail, the pigtail will have two openings and you'll transduce from both. So the distal opening will be in the LV, the prox will be in the aortic arch, and you'll compare the pressures side by side simultaneously. For this one, you just have to ensure that before you advance that tip of that catheter into the LV, that the waveform and pressures match perfectly in the proximal aorta between the two transducers. So if your waveforms are off proximally, then it's not going to be an accurate reading once you drop into that LV. All right. So that is your coronary angiogram and your left heart cath. Remember, that's arterial. That's going to be your bread and butter. You're going to do lots of those. Third diagnostic procedure you're going to see somewhat frequently is going to be your right heart cath. So for your right heart cath, this is going to be venous access. They're going to use this to evaluate things like pulmonary vascular disease, look at the left heart filling pressures for pulmonary hypertension, your heart failure patients. It's just going to give more data, more accurate data for the physicians to treat these patients. This venous access, areas where they typically get this access is going to be the brachial or right in that anacubital space. I know at our hospital, we will get right AC IV, and then the physician will clean it really good. The physician will wire that peripheral IV and then put a sheath in over it. You can also get right internal jugular, right femoral vein. Really, wherever there is a vein that you can get access in, you can do a right heart cath from. For you ICU nurses, this is a swan. If you worked in CVICU, you're very aware of what a swan is. That's what this is. With your right brachial access, there's a very low incidence of having to go from right brachial to like a right IJ or a right femoral vein. It's 0.3 to 0.8% chance of having to transition from that initial brachial, which if you remember with your arterial access in that right radial, you have a 4 to 8% chance of transitioning. We're not even at like half a percentage most of the time. That right brachial access decreases fluoro time and radiation, about 2 minutes of radiation and fluoro time for patients. When you can't get the swan in, the incidence of having to put in a guide wire to help float that catheter in is very low from brachial. Like I said, we're going to use a swan catheter for this right heart cath. That's just a pressure catheter specifically designed to do these right heart caths. A swan doesn't need a wire. 100% of arterial left heart catheters are going to need a wire to get in and out. The swan can go in with no wire. There is a balloon at the tip of the swan. So they'll get the swan in through the sheath. They'll advance it past the tip of the sheath. And then you'll hear the physician ask for the balloon up. So if you're in the right brachial, they'll wait till they kind of get up to the superior vena cava before they put the balloon up. But they'll put the balloon up, and this helps the swan float with the blood flow where it needs to go. So the swan will go in through the superior vena cava, the inferior vena cava, you're coming femoral, into the right atrium. It'll advance to the right ventricle. It kind of does this little loop-de-loop, goes into the pulmonary artery, and then you'll advance into the pulmonary artery and you'll get your pulmonary wedge pressure. So for your pulmonary wedge pressure, you basically float your catheter up until it stops with that balloon up and it occludes the artery. This way, you are getting the pressures from the left atrium. You're seeing left atrial pressures with the wedge. You'll get your pressures there. The physician will deflate the balloon, pull into the pulmonary artery. You'll get your pulmonary artery pressures. Are this patient having like pulmonary hypertension? PE patients will be very elevated. You'll then pull it back into your right ventricle, get a right ventricular pressure, and the right atrium, get a right atrial pressure. Couple of different tests that you can do during this procedure is thermodilution. So this is going to be a special cord that you're going to need to locate. One side has a thermometer, the other side attaches to your Swan catheter. So depending on your facility, we just take the thermometer on the one side and tape it to the outside of a hep saline bag. Some facilities will put it inside the hep saline bag. You need to have it attached to the saline that you're going to use for the procedure. So the thermometer has the temperature of the bag of the saline that you're injecting. There is a thermometer at the tip of the Swan. So when they inject this fluid, the Swan recognizes the temperature of the fluid you just injected, and then it tells you how long that fluid gets back to the tip of the Swan. So it's an indicator of cardiac output. They usually do an average of 3 injections to get that cardiac output and cardiac index number. For oxygen sats, they will get some blood from the pulmonary artery or the right atrium, and you'll put it into what's called an AVOX machine. This machine is going to kick out a hemoglobin and an oxygen sat. There's special cuvette. You put a little bit of blood into this cuvette. It has a hard side and a smooth side. The hard side goes on the filter side of your AVOX. You're going to compare whatever oxygen sat you got from the PA, the RA, so your mixed venous sat, compared to your arteria sat. If you have arterial access, you'll draw a sat from there. Otherwise, you can just use your pulse ox number. And this just gives an indication of your oxygen consumption by your patient. The oxygen consumption from your arterial sat to your mixed venous sat is an indicator of your cardiac output. Those are your basic testing that you're going to do in the cath lab. I'm not going to get into the weeds on the right heart hemodynamics. I'll put up the hemodynamics on the screen, but there's some really great resources out there on right heart hemodynamics, where the blood pressure needs to be, what the blood pressures mean. I just want to do kind of an overview on what you will see, what the diagnostic is, and really touch base on the coronary angiogram versus left heart cath, because that can get a little confusing when you're first in cath lab, because everybody just calls everything a left heart cath, and they really are two separate procedures. So thank you for your time. Thank you for listening. I'm going to keep putting out these kind of overview videos. Hopefully you're getting something out of these, learning some stuff. Let me know in the comments what you would like me to touch base on, and good luck out there. Stick to it. Thank you.